Invite my first speaker without waiting, Dr. SUGATO, the Chairman, Scientific Committee of West Bengal Ophthalmic Society, a prolific surgeon, a teacher, has experience both in India and UK, and he'll be showing us the assessment and decision making. Yeah. Over to you, SUGATO. I would invite my co-speakers to co-instructors to be on this stage. Dr. Priya, please. And Dr. Surya. These are the two which are there.
Good morning, everyone, and thank you, Dr. Ajay Pal, my mentor at OSWB, for giving me the opportunity to speak here in this prestigious instruction course. I'll be speaking on assessment and decision making, where the beginners have their dilemmas in managing ectopia lentis. So we all know that the zonules are microfibrils which actually suspends the lens 360 degree. It extends from the ciliary body to the anterior and posterior capsule in the equatorial region of the lens. And when there is some loss of the zonules or weakness, we get the dislocation of the lens, subluxation of the lens, and when the lens is completely outside from the lens patellar fossa, we get what we call dislocation of the lens. The beginners can have dilemma in diagnosing, in management, in preoperative assessment, and which surgical technique to choose from. So to diagnose any case, we need to know the etiology, and trauma is the commonest etiology of ectopia lentis. The good thing is that the trauma, zonular dialysis or zonular weakness is non-progressive, whereas there are other conditions which are primary ocular disorder associated with ectopia lentis, hereditary ectopia lentis without systemic disorder, and there can be systemic disorders which are associated with ectopia lentis. The ocular conditions which are associated with ectopia lentis can be congenital glaucoma, retinitis pigmentosa, pseudoexfoliations, aniridia, and also high myopia and hypermature cataracts. Whereas systemic conditions which are associated with ectopia lentis can be Marfan syndrome, homocystinuria, Well-Mascrasani syndrome, and also Ehlers-Danlos and few other causes. And you have to know, the beginner should know that in where the lens dislocate, like in Marfan's is dislocate superiorly, in homocystinuria is inferiorly, and in Welsh-Mascrasani it can move forward and can cause complications such as angle closure or pupillary block glaucoma. Now, we need to know the causes of decreased vision, which can be due to fluctuation of the lens into phakic and aphakic position, due to significant hypermetropic or myopic shift, and also monoocular diplopia. And there can be loss of accommodation as well. And the complication, as I have already said, can be pupillary block glaucoma due to forward movement of the lens and endothelial cell loss. So a beginner should take good history in cases of systemic diseases, also take history of ocular trauma, skeletal problems, history of familial problem like consanguinity, mental retardation, and unexplained death in the family. And they should do a thorough ocular evaluation extending from the full BCVA to anterior segment examination, including gonioscopy, which is very important in this situation because there can be trauma-related problem, there can be angle-related problem in congenital cases, and also detailed fundus examination is very important. And if you are planning surgery, then evaluate the lens position, the degree of the zonular loss, and try to see if there is any vitreous in the anterior chamber. And other investigation as advised by the pediatrician in cases of congenital cases. So where the dilemma in the management? The main dilemma in the management is whether to manage it conservatively or whether to do surgery. Now, conservative management can be done when the refraction is stable. You can prescribe glasses or partially occluding contact lenses. And in some cases, you need to do laser iridectomy if there is chances of pupillary block or angle closure glaucoma. And surgery is required when the fluctuation of the power is there, refraction is there, whether there is lens-induced glaucoma, there is cataract associated with ectopia lentis, and when there is impending dislocation of the IOL, of the lens, sorry. So, what the dilemma in the surgery? Any beginner should know how to grade the subluxation. It can be graded in different way. If you dilate the pupil and if the aphakic area in the pupil is less than 25%, or whether it is from 25 to 50%, or whether the lens is subluxated in such a way that the aphakic portion is more than 50%, this is one way of grading. The other way of grading is according to the zonular clock hours of zonular loss, such as mild when there is less than 3 clock hours loss, and it can range to advanced when there is more than 9 clock hour loss of zonules. And all the beginners should be familiar with these rings and hooks and segments so that they can use it in the right way. So the capsular hooks or the iris hooks, they aids in the rexis completion, aids in the CTR insertion, and also during the phaco, it gives stability, and also during the IOL insertion. These give transient or temporary and support in the anterior-posterior support, whereas the CTR, they expand the capsular equator and buttress the area of the weak zonules and stretches and tautens the posterior capsule to enhance the PC safety, and also it recenters the mildly subluxated IOL in the bag. Sometimes you can get away without fixing the bag in mild subluxated lenses, and decrease PCO chance as well. And the size of the CTR, we should know how to choose the size. It actually depends on the axial length of the globe. And the beginners should know when not to use the CTR, such as in anterior capsular tear, in posterior capsular rent, in incomplete rexis, and in severe subluxation. CTR will not help. We need to fix the bag in those situations. And here comes the role of the capsular tension segments, where we need to know that there are right segment and left segment. We just cannot just invert the CTRs, because because this area which is fixed over the capsule, anterior capsule, is in a slightly, is it in auto forward mode or what? It is slightly in a superior plane than the normal segment, and it goes above the capsule. So we choose the surgery according to the zonular dehiscence size. If it is superior up to 4 clock hours, you can use CTR, or you can sometimes get away with just implanting the IOL with the haptic being used to stretch the bag. But in cases of inferior dehiscence, you have to either use CTRs if it is less than 3 clock hours. You can choose modified CTRs or segments if it is more than 6 to 9 clock hours. And if it is greater amount of subluxation, then you can also consider sacrificing the lens capsule and arrange for scleral fixated or iris clip or anterior chamber IOL. And you have to, the beginners should be familiar with all the techniques and can take the help of his retinal colleague if vitrectomy of the sublens, if it is dislocated in the vitreous, or fragmatomy if it is a hard cataract. Few tips of do's and don'ts. Always try to maintain main incision away from the zonular weakness. Try to initiate the rexis away from the zonular weakness. Use high molecular weight viscoelastic to plug the vitreous away. And it is better to use micro capsular rexis forceps. They are preferable in these situations than needle. And you can use the technique which don't put stress on the zonule much. All this will be discussed by our speakers, eminent speakers, in the next few seconds. So beginners should be aware of the complication, post-operative complications as well, so that they can manage them if and when required. So in conclusion, subluxated lens need a good thorough pre-op evaluation. Surgical plans has to be individualized, and long-term follow-up is required. For the beginners, they should attend instruction courses, observe and assist the experts to gain more insight and confidence, and they should, when they start operate, ideally they should start under supervision. Thank you very much.
Thank you, Dr. SUGATO, for giving us a nice insight into how a beginner should begin with. Now, what do you think the first cases should be for a surgeon, and with how many experience and how many years or how many cases he has done, especially putting in a CTR? And CTR is the first thing they would all.
So I would say in cases of putting CTR in subluxated lenses, they would first put CTR in patients who are non-subluxated lenses, like in high myopia where it's quite easy to put the CTOs, and they should learn the technique. Similarly, same thing, they should try putting the capsular hooks in normal cases, in few cases, so that they can do it quite easily and efficiently when they get a subluxated lens. And for a subluxated lens, if I had to choose, I would choose a patient who has minimal subluxation in the beginning few cases, not to go ahead with a subluxation which has quite a lot of subluxation.
Yeah, and again the salvage mechanism, and when this fails, what next? I mean, they should be aware of doing an aphakic patient, whether they will do in the second stage or first stage, or I think the IOL option would be spoken to us by Dr. Priya. Means in case you fail, I mean, get ready with an SF IOL, get ready with glued IOL or Yamani, whatever technique, I think. Thank you,
Thank
Dr.
you very
SUGATO,
much.
for giving
Thank
us.
you for